Welcome to Medicine Redefined, a podcast focusing on helping you reclaim ownership of your health. I'm Dr. Darsha.
And I'm Dr. Altamash Raja. We're your hosts, here to challenge conventional practices and uncover the stories behind pioneers shaping the future of medicine. Our conversations not only focus on the individual level to dissect common practices for health optimization, but also zoom out to enhance systemic change.
Join us as we look to break the status quo, move the needle forward, and put the health back in healthcare. Our guest today is Dr. Ravi Hariprasad, the founder and CEO of Intuitive Mental Health, a startup focused on partnering with primary care physicians to deliver comprehensive and personalized mental health support. Dr. Hariprasad obtained his medical degree from the University of Pennsylvania and completed both his master's in public health as well as his psychiatry residency at Harvard University. Dr. Hariprasad is well versed in both Western medicine as well as holistic and complementary perspectives such as Ayurveda. His early experience as an engineer and an entrepreneur have helped him understand system design, root cause analysis, and solution development and implementation, all of which he brings to the table in today's conversation surrounding our mental health crisis. Let's dive in. Hey everyone, real quick. We are close to rolling out a newsletter containing high-yield notes for our guests and tips and tricks from us. We want to put the health back in healthcare and want to help you do the same by giving you the necessary information to live your best lives and provide value to those around you. Make sure to head to medicineredefined.com where you can input your email and stay up to date. All right, thanks. Time for the episode. Dr. Ravi Hariprasad, first off, thank you so much for being able to come here tonight onto the Medicine Redefined podcast.
A pleasure.
Secondly, so we connected on LinkedIn and I was really amazed by your journey. You sent me a beautiful intro video about you and your journey and how you really came to understand medicine and truly the why behind medicine. And, you know, we need the audience to hear that, especially from you. Exactly what was your journey, especially with the engineering background? How did you go about trying to build all these skills and what eventually led you to medicine?
So that's a big question. It's how do you summate an entire life's journey in a few words? But I was the son of a brilliant physician. My dad was a doctor in rural upstate New York. I was a first generation immigrant family, and I grew up watching him take care of patients. And he was a little bit of a cowboy. He could do anything. An internist who could put in pacemakers, if you can imagine that. And so he is also a master diagnostician. And so from a very early age, I was getting exposure to medicine. But it was actually the technology that was my first love. When I was 5 years old, my father bought me a computer. And while my brother was enjoying the video games on it, um, I was busy programming and figuring out how to write software with it. And I loved it. And it ignited an entire journey in me of a fascination with technology. So that kind of thread went through, and then I eventually went to Cornell to pick up an engineering degree, and I specialized in operations research engineering, which is kind of like, you know, applied mathematics. How do you get if you have FedEx that has to move 1 million packages overnight for $9 and has 50,000 aircrafts and 1 million workers, how do you make that happen for $9? And some serious mathematics, and thinking about the world through that lens has been incredibly transformative for me. In addition, I picked up computer engineering. But somewhere along that journey, I felt the gravity drawing me in to follow my father's footsteps and to apply those skills towards healing people and to have that connection with folks and like be able to, medicine is the opportunity to be. Have that human connection of service, and at the same time, you are highly technical. It's scientific, and it's the ultimate engineering problem to solve. The human body is amazing, and so I eventually migrated towards medicine, and I did that at University of Pennsylvania. But as fate would have it, in my third year of residency, my car got broken into. And while I was seeing patients in inner city Philadelphia, West Philly, I heard an alarm go off. And when I ran outside, I saw someone making away with my brand new little laptop. It was a Toshiba Libretto, if I remember right. Like it was like this big, and I was so proud of it. And I had it because I jury rigged the first GPS system out of it, sitting on the dashboard, and I was navigating with my homebrew GPS back in the day before it was even around. And so at first I was like, "Oh no, my GPS is gone!" And then a few minutes later, I realized that my $2,000 laptop was gone. You know, it's like as a med student and resident, you're in your training, Darsh,
Yeah.
and it was a painful sting. And I'm on my way home, and a piece of glass actually pierces my butt. And like I'm thinking to myself, this sucks. What if I had a piece of software on here to track the location of it, find the bad guy, and like secure my data? That would be a great idea. And I called up a buddy and at MIT and pitched him the idea, and he was like, "Oh yeah, that's killer. We should do it." And I realized that at Wharton Business School, the next morning was their first ever entrepreneurship competition, and this was the height of the first .com era. So I pulled an all-nighter and submitted a business plan for Lucira Technologies, which was my first startup back then, to build a company that would develop this technology and distribute it on laptops. And we won. And then I called up my buddy and I was like, "Oh my God, we got to apply to the MIT one too." And we won that one too. We're a semifinalists overall. The MIT 50K competition, that was seriously competitive. But then we also won first place for the Morgan Stanley competition. So three big competitions in one year, and all the investors came. And I dropped out of medical school, and we built Lucira Technologies in Boston. A little digression, but
Mhm.
that was the company where the technology and the patents for Find My iPhone were first developed.
Hmm.
And it was a wild ride playing that company out. And at the end of it, it was the end of the .com era. We had some hard times with the business. While technical win, everyone knows and uses the solution, we didn't hit the financial success we wanted. And that sent me into a depression, which then gave me some thoughts on like what I wanted to do next with my career. Did I want to start another company? Did I want to go finish my medical degree? What have you? And that was when I realized that the fundamental question was our mental health.
Mm.
Right? Like I saw a lot of investors, a lot of successful people, and I just went through so much as a 25, 28-year-old guy, and realized that if you don't have your happiness, if you can't view the world like in peace, you really don't have much. And that was when I vowed that I was going to dedicate the rest of my career to the pursuit of figuring out what the story is with the human condition and and our happiness. And I was going to figure out how to automate, replicate, and scale high quality mental health care for everyone. And so I made another pivot in my career trajectory and started studies at Mass General in psychiatry, and in parallel picked up a public health degree there to complement the skill set for that whole population health side of me, and sought my fortune. I moved to California, to Oakland, and took a position at Kaiser, being both a clinician and leading quite a bit of research and technology initiatives aimed at innovation in mental health care.
Wow. I mean, all of that sounds like a TV show that I could watch on Netflix. Maybe two seasons. I don't know. But no, it's an incredible journey, right? Everything you talked about, how you connected the dots, and for you to change your philosophy too, right? Throughout these times. I mean, I can tell you're somebody who really values perspective and really values the learnings, right? I mean, you're getting your laptop stolen, but at the same time, you almost see like a bright spot, and you're saying, well, how can I create a solution for this, right? So you mentioned psychiatry residency. Did you do another residency prior to that?
No, I left medical school, and
Gotcha.
I got lucky. Wharton Business School gave me credit for my entrepreneurial adventure because I won their business plan competition. Somehow we got that to work. So I'm the first 3-year graduate of the University of Pennsylvania, and then I went straight on to residency at Harvard.
Okay. So it's interesting, right? Because I mean, you mentioned your engineering background, and most people that are engineers in medicine most likely go into like surgery or maybe prosthetics, but something more hands on, something that they can really look at as a puzzle. I mean, one can argue that psychiatry is truly a puzzle of the mind. But you also mentioned that you got into medicine because of connection. How did you view psychiatry? I know you were on this quest to figure out mental health and happiness and how people think, but how did you tie in the engineering and the component of connection, aside from developing technologies when it came to your residency? Because we know that residency is kind of standardized, right? I mean, you got to go through the motions, you wake up every day, it's kind of redundant at times. And you're seeing the patients in front of you, sometimes trying to make a nebulous diagnosis. How did you incorporate those core values that you grew up with that you really wanted to bring into your ventures?
It's fascinating, right? So one thing I didn't mention in that story is this deep spiritual thread that's been with me since my early age, right? And I studied in great depth a field of philosophy called Advaita Vedanta. And this is the non dual tradition of philosophy from the Vedic Hindu tradition. Um, the idea there is it's basically the understanding of the philosophy that we're all one, that there's no separation between subject and object. And how can that be? Right? Like, what does that even mean? And this ancient wisdom was a guidepost that helped me understand that everything is fundamentally consciousness, and from that consciousness, there is an experience of the world that we're in, and all of its various forms. Um, I don't want to go too far down that rabbit hole, but it was an incredibly influential and important aspect to my development. And that led me to understand that the soul of medicine, the heart of everything, lies in the psychology. As we think we are, as we feel, so we become. And the body mind connection in recent years has been recognized more and more with growing evidence. But the ancient philosophy points out to this lack of separation. And at the end, to grab your physical health, one has to master the psychology, the the more subtle aspects of living and being. And so psychiatry was a discipline that I thought would take me closer to that than any other field of physical medicine. I also liked the art form of it. Right, like in physical medicine, I felt that there was too much was repetition. Person with asthma, give them inhaler, add steroid. Doesn't work, add more steroid. Check in, figure out how many puffs of albuterol they're using, titrate from there. And I thought I'd get bored with it at some level, versus the art form of psychiatry, never a dull day, and the thought that can go into understanding and being with people on their journey along with that connection was something that I yearned for. So it was very much a way to bring my spiritual side with my medical side with my mission and weave them all together.
Ravi, I mean, this is so interesting because, you have this existential point of view from your background, and then you go into psychiatry. And, we went into medical school, and, Darsh is both for training a little bit after, your time. And as far as, I mean, at this point, I don't know if there's DSM-5 or DSM-6 where we are. During my training, five, we're still on five. During my training, it was really, I loved psychiatry because it was just straight repetition, and it was just understanding the criteria, and it was just understanding pharmacological agents and their mechanisms of action. And this is one of the issues that a lot of people who are working, mental health providers and people who are making psychiatric doses or mental health diagnosis will argue. Will say, okay, does this person satisfy that criteria, right? Like on the DSM-5, and that's a big problem because a person's so much more than subtle criteria. That being said, though, right, when we're going through residency training, when we're in the quote unquote traditional model, you do have to play the game. so to speak, to make the appropriate diagnosis so the patient get the appropriate treatment. Were there times where, because it sounds like this was clearly at odds with where your background was and your thinking was, were there times that this ended up being very frustrating from you and made you want to just step away? Because that psychiatry is also 4 years of training. Am I correct on this? Yeah. And if so, like, how did you cope with that?
It's a really good question. Yeah. So there's a reductionistic view that can be applied to psychiatry as well, for sure. In fact, many of the scientific advancements and the pharmacological advancements have been made because of that, right? With the advent of the DSM, we could now categorize patients coming in the door and have inter-reporter consistency. Like, this psychiatrist will call this person major depressive disorder, this one will as well, and we can understand. So now we can bin and sort classes of humans into buckets, and then we can run our randomized control trials and figure out what medications work at what dose and what way. I mean, all interventions, and build an evidence base for the profession. And that was something that was completely lacking prior to the DSM. One person would say this is neuroses, another person would call it anxiety, another person would call it personality disorder, and then they would sit there and argue, and they didn't even know what they were arguing about because there was no definition. And so it really launched psychiatry into the era of modern evidence-based medicine. And I respect it for that, right? And it was hugely important. On the other hand, it was a creation of a empirical science without mechanism underneath. And that's a problem. We're taking clusters of symptoms like the criteria for depression, sleep, lack of motivation, guilt, energy, concentration, appetite, psychomotor retardation, suicidality, and then saying that people who meet these buckets have a disease. But, eh, uh, really? Maybe. We just know that they're all kind of the same. And this is the problem with evidence based psychiatry, and why you see like these crazy trials that show that SSRIs, the antidepressants, don't work. It's not that they don't work, they work for a person who has a need for a boost in serotonin in order to help with their mood disorder. And there are lots of people like that. But then there's the other guy who's sitting there watching Netflix all night long and not sleeping and is chronically sleep deprived, and then waking up fatigued, low energy, low motivation, overeating, and not feeling like exercising, and then does it again the next night. And then there's the person who does the same thing, but in the morning they grab a triple shot coffee at Starbucks and down it so that they're ready to go. And they get their music on their headphones and they're jamming and they run like 10 miles. And then they get a panic attack in the middle of the day. They go to the psychiatrist who goes to the DSM, check, 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 check. What you got here, son, is panic disorder. And we're going to give you an SSRI, right? And then mileage may vary on that, right? Like, I mean, it may work, may not work, but then that accounts for the problem, right? So, so I had an inherent problem with this going through training because I was with the guys who made the evidence base. Literally, these were my teachers. They were the ones who wrote the textbooks, and I would challenge them on these basic observations. And let's just say the answers were not gratifying to me. And it was around that time that I started picking up the study of Ayurveda, right? And like, for the people who are not familiar, Ayurveda is a complementary and integrative healing system of India, of ancient India. And it stems from the same Vedic philosophical knowledge base that I had been studying. So there was a completely consistent healing system that was holistic and integrative. I think Ayurveda probably is the grandest study of human wellness, and has a vision for a human not different from its environment and from behavior. And in fact, in Ayurveda, the core principle is the food that you eat and your behaviors is your medicine. And so this grand lens started beating in my heart back then. And then I viewed psychopharmacology as just a tool, as with psychotherapy. As with traditional Chinese medicine, as with supplements, as with everything else around this vision that unified spirituality, mindfulness, being, and it synthesized these lenses for me in a way that was written 3,000 years ago, signed off on, and not one syllable has been changed because it took them 3,000 years of academic work to get to that point previously to that. And armed with that, I don't know. I was able to tolerate everyone and learn from them and understand the limited context that all these things are coming in. But but I would be synthesizing how to use them, when to use them, for who, when, and that became formidable. And it took the practice of psychiatry to a whole new level for me, in terms of it being gratifying and being a part of my own journey and being able to feel like I'm doing something really special for the people I'm blessed to serve.
Yeah, I'm glad you brought up Ayurveda. I mean, we've had a couple episodes now, one with Dr. Jyoti Patel talking about gut health, microbiome, and Ayurveda, and then as well as Dr. Shivani Gupta talking about the basics of Ayurveda, the doshas, all that. So, listeners who may not
Nice.
understand, those are definitely good episodes to go back to and refresh before you come back to here. I mean, maybe we can touch on it more when it comes to mental health and learning about how to use it in psychiatry in a bit. But I think this is a good time to talk about the current gaps that are occurring in mental health. I mean, the way you're talking about it is very multimodal. I mean, your approach especially. And it seems though, I feel like to me and the general public that when you go on social media, you see, variety of coaches talking about different types of therapies. In medical school, we always learn about different types of pharmacology, different types of therapies. But yet, we seem to always go back to this kind of checklist manifesto in a way. What are the current gaps that we are experiencing that come to mental care in the US?
Well, the first is an epic supply demand mismatch,
Mm.
right? It's always been a problem. And mental health services were never designed to be a population service, right? The psychoanalysts who need five sessions a week, each an hour and a half sitting on a couch and free associating, never thought of themselves as public health interventions, right? But somehow, when they got Thorazine and got a few antipsychotics and started getting medicine, and then the advent of the DSM and an evidence base, it turned into a medical discipline. And they carved out a niche. And so this a niche kind of service line turned into something that needed to take care of populations. And that was the beginning of the supply demand mismatch. And so here, just to my practice of psychiatry, um, comparing pre-COVID to post-COVID numbers, the call volume has gone up about fivefold. Just to give you a context of how much demand has increased for mental health services through COVID. And I think that's largely because of a destigmatization and also a deterioration, like this amount of social stress on us, particularly having to pretend that nothing happened over the pandemic and everything's fine and we're good to go. There's a lot of unprocessed baggage in society from the trauma from that. Yeah, there's a gap in the supply demand mismatch that's epic, and it's also an aging workforce. Psychiatrists. 3 years ago, there was a statistic that 50% of psychiatrists in the country were going to retire in 5 years. All right, so we're 3 years into that. And so that's another problem. There was a large period of time where it wasn't considered sexy to be a psychiatrist. Mental health is having its moment, but now that's another 8 year delay for a med student to be born and turn into a psychiatrist. So we're in that gap, and no level of production of psychiatrists is going to yield a solution to this problem. And then there's issues and questions around the model of care. Is this the most appropriate way to take care of people? Is it the most efficient? And in this supply demand mismatch, we've seen a rise in the psychopharmacological management of mental health conditions, and probably a lot of excess prescribing, as we were talking about in the previous example of the caffeination. Yeah, there's a lot to be said about that.
Ravi, you mentioned overprescribing just now, and that was actually one of my follow-ups I had prior to this conversation is how much of a bias is there from the provider when it comes to prescribing? For me, I was talking to Altamash about this yesterday. For me, I don't see mental health personally when I look at people, quote unquote, as a true crisis for a lot of people. I think it's just, hey, they are overstressed and there's ways to maybe cope with it. And that might lead me to not take it as seriously or maybe not even prescribe the proper medication, if it is something serious. Whereas on the other end, you might have some prescribers who have seen depression in their family members and have seen the miracles of SSRIs. And so they treat every case as if it's their loved one and would overprescribe. How do we get more nuanced about that? You did mention a little bit kind of about precision medicine. I mean, are there ways now that we're looking at specifically serotonin levels or that we are really dissecting the individual to make sure that we are diagnosing correctly?
Yes, you're talking biomarkers and markers of mental health conditions. Yeah, my view is how many billions of dollars of research and efforts have gone into finding a hemoglobin A1C or a blood pressure marker for our mental health conditions. Uh, it's all speculative, and it's not clear that it's moving the needle. We may get there at some point, but there is remarkable progress being made with digital phenotyping and predictive behavioral analytics, watching a person's behavior and from that inferring how they're doing. Um, Prior to embarking on this course with the IMH, I was working at a company called Ginger. That was that a lot of people know now, Headspace Health, and that company's origins was in data science, and they were working on predictive analytics so that they could actually look at how a person's using their smartphone, their wearable devices. How many times they're playing Candy Crush in the middle of the night. And these things are actually highly correlated with the industry standard rating instruments for severity of illness. Of course, it doesn't tell us cause, and that's a different matter, but they do play a role. Um, so I don't want to go too far afield without addressing your question of overprescribing. I think that the trick here is understanding what the problem is as best as you can. And a lot of times it's about lifestyle. And in my view, there's a burgeoning field of lifestyle psychiatry that's coming out of the lifestyle medicine movement from the American College of Lifestyle Medicine and other people who are working on this. The functional medicine doctors are doing some work here. And the idea is to understand the situation more holistically and identify what the roots may be. So, like we talked about caffeine, we talked about sleep. We talked about primary sleep disorders, huge. The number of people with sleep apnea who masquerade as depression. Um, Exercise, mindfulness, diet. These variables actually, like if you look at the DSM criteria for depression and reverse it, it's behavioral, right? Problems with sleep. Okay, then why don't you just help the person sleep? Oh, they're watching Netflix and drinking too much caffeine. Why don't we start there? Right. And so this common sense or intuitive mindset, it's one of the reasons why I named the company what it is the approach to take. And once you've gotten rid of the obvious things, then maybe you can look at a medication trial. But it should be done in that sequence. And I think a lot of the problem is it takes a lot of time to be that thorough and to like spend the time with someone to understand those things. And this is where my great hope for leveraging health coaches, using generative AI and other technology can fill in that gap to a busy clinician.
Yeah, it's obvious, but it's not easy, right? And it's also from a short-term perspective, it's an inefficient business model, right? That takes a lot of time. It takes a lot of upfront investment and energy, and not to mention human beings are difficult, if I may, right? And people are somewhat stuck in their ways, despite wanting to get better. But again, this concept of instant gratification in our world, particularly with social media and dopamine, I mean, that's only getting stronger. I don't see us getting away from that, right? We're only reinforcing that more and more. And so what you're suggesting in terms of the behavior modification, that takes a lot of time, and that requires active participation on the patient's part too, which again, a very significant challenge as well. And so, I guess, I know Darsh has a couple other follow up questions, but because we brought this concept up, I want to ask you in terms of when you were thinking about that, you said that this is very, very intuitive. And you're like, well, why aren't we doing this? Why aren't these approaches being? And I don't want to suggest that, finances and be a conspiracy theorist is a simple way. But again, for somebody who's early career physician, Darsh is still a trainee. These are a lot of the questions that we're asking, my students are asking, and I think the next generation of physicists are asking, why is this not the case? So as somebody who is a bit more seasoned, do you care to share?
Yeah, no. I mean, God, the reasons are several, right? Um, where do you even begin with this one? But I think you highlighted, Altamash, a lot of the reasons. We got a business model situation, right? You got 6 minute primary care visits. Now, every time payments get cut on PCPs, what are they going to do? They have to pay their staff. They have their overhead increasing. So the only solution is to slash the office visit down from 10 minutes to 8 minutes to 7 minutes to 6 minutes and keep going with it. CMS actually removed the time requirement on office visits with the coding changes in 2021, and I think it's part of the reason they're still slashing payments, and so their solution is to be allegedly more efficient. So then it takes time to figure this out. That's one. You pointed out to the business model, like that's entrenched in the ethos with the pharmaceutical and medical industrial complex. There's something to that as well. Like Ambien, it works, but the problem is that a person needs to stay on it, or they go into withdrawal and then they need more. So that serves the pharmaceutical industry. There are cases where you need these medications and they have to be used responsibly and monitored, but again, that takes time. And so then there's also the training, right? Like it takes a unique lens to shift from, because we're all trained and you're trained and I was trained from doctors who are practicing in a conventional model. And so how do we know what we know as physicians? We know what our teachers told us. And so that perpetuates the cycle. That's another issue. Um, I do think that an era is definitely coming. There's a rising awareness in the population and people that in order to move from sick care to healthcare and in order to thrive, we have to move away from this. And I think that the availability of knowledge, like for example, this podcast you're producing, it brings this knowledge and these insights to educated consumers. So that's potentially a disruptive force on conventional medicine or an opportunity for transformation within the profession. And then the psychological aspects, right? The psychological aspects I should comment on as a psychiatrist because, well, humans are these little machines that seek after what feels good and avoid that which doesn't feel good. And it's something else to overcome that. But uh, if you think about it, staying up watching Netflix feels good tonight, and then the next day, I'm completely sleep deprived, sucking wind, and suffering. The issue is a certain ignorance about the linkage between the behavior and how I feel. And so, in my view, being able to teach a person the association and let it be muscle memory for them uh, is is the root of behavioral change. So if I have a patient who's staying up too late watching TV, I'll make sure they get the point that they're paying for it the next day. Just like when they drink too much and they have a hangover the next day, they know what caused what. And then as soon as that association is tight, there's many of us that'll moderate the number of drinks we have in a night explicitly because we don't want to get hungover the next day because we have to work and other such things, right? But that lack of connection between cause and effect is does Netflix win if we don't stay up all night watching? Does the people serving up ads win if we don't stay up all night watching? And so there's a certain commercial bias to play on that. I mean, if this was all post World War II behavior to sustain the economy. How do you convert from a wartime economy to a peacetime economy and not crash it? And that was the rise of American consumerism We start buying things because we want it as opposed to because we need it. And that was actually by design, right? Freud's nephew, Bernays, was the architect of it. And if you watch that HBO series Mad Men, it shows you the rise of that in the United States. And so we have to we have to like slowly get ourselves away from that thinking and restore an objective lens on what's causing what. And if you don't do that, if you try to coach a person and if you tell them they're wrong, and if you do any number of approaches to behavioral change, you fail. But when a person actually understands and sees the effect, you actually find that the system starts auto correcting in due course. Um, so I view my job as a physician is to point these things out and hold a mirror up for people. And I'm good with that. If someone chooses after understanding to suffer, it's great. Like it's on you. Like, what do you want me to do? You want my help? I'll help you. But now you know why.
Yeah. How do you get people to change their behavior though? I mean, I love that you use the word winning, and I'm a big fan of gamifying things, right? And so when we talk about where our attention goes or the choices we make, always thinking about, well, who's winning, right? Is it the advertisements and Netflix winning? Am I winning? If I'm going to grab that Kit Kat bar, is it whatever company, is it Hershey's? I don't even know. Maybe I'm not Hershey. I should know that. Are they winning, or is it, me gonna win in the end? So always kind of thinking about like, hey, what's in it for me? I think is a great way to kind of shift that mindset. But to do that 24 hours a day when you are hangry or when you're sleep deprived or when you're stressed is really, really difficult to do. So when you talk about, hey, I'm here to help you, what are those strategies that you actually implement, from your expertise to actually change that behavior for people and to shift their mindset?
Right? So the first phase is the education component, right? Like knowing what causes what and why I'm suffering. Then the second phase is something that requires a person to ask for it. They need to ask for help. They need to want to solve this problem. They need to want to rise above these tendencies, right? And have an intention for it. And that's really important. You can't change a person. A person has to make that conscious choice to choose health over disease, to choose happiness over suffering. Um, so important. Then the second thing is, how do you equip them to succeed, having thus decided that they want to, right? And this is where a few lessons from ancient philosophy, from ancient wisdom traditions, comes to bear. And I think the fundamental answer is mindfulness. So in life, we're looking through a windshield. Like imagine we're a car, we've got our sense organs, and we're watching any number of things. And like at every moment, there's a choice that has to be made, right? Like, okay, candy bar. Do I eat it or do I not eat it? Right? And in the usual state, people are unconscious. They're not actually present, right? And you can see this most commonly with smokers who are outside puffing and looking at their phone the whole time. They're not actually paying attention to the sensation of the smoke, the feeling of the burning sensation in their throat, the little bit of pain that's in their lung as the smoke is filling it, the nastiness of the smell as it comes out of their mouth. It's replaced with this mindless smoking while they're sitting there doom scrolling on their phone. So their attention is away from the object of what's going on here, and that leads to these poor decisions moment to moment in the stream of life as we move through it. And so then you're hangry, like you're just coming off a 36-hour shift, Darsh, and you've got a little bit of a headache. You could eat something healthy and you see a candy bar. You probably are just going to chew on it on your way home. And if there was this way for you to stand back and be centered in yourself and notice the craving in your mouth, the saliva being developed, to notice your desire to eat the candy bar, to notice the pain in your head that you're trying to solve for, and to breathe with it and not take immediate action, just to watch and breathe a little bit. You create that space, and in that space is freedom. Literally, freedom exists in that moment where you now have a choice to say, wow, Darsh really wants that candy bar. Isn't that fascinating? Hmm. And then to ask the question, what is the correct course of action? And then to take a moment and then to say, okay, I need to go get a bowl of oatmeal. I need oatmeal now. And there's some in the cafeteria on my way out. And let me just pour it down my throat and get the hell out of here. And like move, right? And so that's possible for you. And the more you do that, the groove like tendencies in the mind to for its automatic behaviors and responses start to fade away. And slowly, behavior change occurs. And you're effectively choosing health over disease. And you actually had a say in it this time. And so then, how do you grow that mindfulness, that quality, that ability to do that, to distance yourself from your desires and aversions, and to ground yourself and to have that space of freedom? And that is the subject matter of all the mindfulness traditions on the planet. And in doing that, you start realizing, oh my God, this isn't just about the candy bar. This is about whether I yell at my partner. This is about whether I decide to waste all of my money on uh, something I don't really need. This is basically the fundamental human issue. And it turns out that those micro behaviors of our lifestyle are just practice ground for mastering this. How do we get to psychological freedom? And that I think is a fascinating insight. And so your mindset shifts. And so the next question is, how do we walk this path of mindfulness and grow? And that's another topic, but I hope that helps give you context.
Yeah, Ravi, this is fascinating, right? I think we all know and recognize that habit change nowadays is super sexy, right? We have a ton of great books coming out on habit change. James Clear's Atomic Habits, which phenomenal book, by the way, but I think it's been a bestseller for several years in a row and for good reason. But I think he is one of the people who talks about is when you are trying to implement a good habit or replace a bad habit, quote unquote, with a good habit, behaviors such as the one that you're highlighting where you might be making bad decisions with smoking, if you recognize that that is one, or maybe being hangry and putting a Snicker bars where you should be eating something else when you're just simply hungry or tired or whatever it is that you're using that as a coping mechanism for. If you replace that in that moment with some other positive behavior, you might recognize that maybe you substituted it something that's more beneficial for you. That being said, though, I think it begs a question of this. We take a step back and we look at it from this philosophical approach that you highlighted or started the whole conversation with. Is it's really about this addictive personality feeding this impulsiveness that we all have deep within, right? And I'm starting to think if maybe that strategy of replacing that loop of impulsive feeling of wanting the Snickers bar or candy bar with maybe a different positive movement like 10 air squats. If that's necessarily a good thing, or if doom scrolling where you won't get the candy bar and therefore afterwards you maybe won't have the guilt or shame or whatever you might have associated with it, because you recognize you made a bad decision, but now you've gotten that dopamine some other way. Whereas the mindful based approach that you're talking about is to slow down and not do anything and just process and sit with that feeling of, oh my God, I really, really want this candy bar. Why do I want this candy bar? And sit there and think about that. Oh, is that because I'm actually hangry or tired or whatever it might be? And so with that preface, I guess what I'm trying to ask is the former strategy that I am highlighting in some of these habit strategy type books that they talk about, where you want to replace it with something else in the immediate nature that still gives you that positive dopamine response, is that ultimately detrimental to this mindfulness based approach that we have?
Oh, that's a great question, isn't it? It's like you're substituting it with another addictive behavior that's less toxic. And so it's a hack. Now, uh, it's fine. At least you're not destroying yourself as rapidly. But I think that there's the middle ground here is once you create that space and you stop and you're watching it and you feel it, I still have that desire. I still need to satisfy that craving or that thing. And how do I solve this problem for myself? And that's where all these techniques file in. I was like, oh, I can go get an apple. It's tasty and it's good and it's not going to toxify my body, right? Or I can go just get decaf coffee. And like, it'll taste good and okay, 25% calf, please. Like I can do harm reduction. So there's a whole range of possibilities that open up to you when you create the space, and now you can use your intellect as opposed to your automatic grooved pattern behaviors. And all these books, everything everyone is teaching, are suggestions and ideas of how your intellect may solve the problem at hand. But until you actually master and make even a little bit of progress on the road of mindfulness, to be woken up and to be present in your day to day living with every decision that's micro decision that's coming at us, yeah, you can read 10 books and nothing's going to make a difference. You'll still do what you're doing. It's pointless. And so that this is the point that gets missed everywhere. Is like, yeah, I want to smoke. And then what? Yeah, I really do. I can feel it in my mouth. I can feel the crave. So, freedom is attainable, right? And that's something. And so, what I worry about is in watching all these videos and reading all these techniques and whatnot, you're making the mind busier and busier and busier. Which is denying presence more and more. And it's really getting some level of silence in the mind that actually causes freedom from thought.
Yeah. It's interesting, right? I mean, there's a bunch of books out there. Eckhart Tolle will talk about this. Michael A. Singer with Untethered Soul. You have James Clear, and they all have their own approaches to clearing the mind, essentially, and really with habit formation. But Ravi, what I'm interested in here is, the listeners need to understand that you're a psychiatrist, right? Like this is what you can do in a session whereas if they go to a PCP and they have three different issues, one of them might be mental health concerns, but they only might get a minute session on that. And it might not even be about anything about, changing XYZ in their lifestyle. What is the current PCP care model like when it comes to mental health? I know you mentioned that there's a supply and demand issue. I would even presume that there's one with just doctors in general, right? Or frontline workers. And this is where your company comes in. So take us through a little bit about the PCP model and where intuitive mental health comes in to really try to solve this issue.
Yeah, no, exciting. Um, so, intuitive mental health is my answer of how we're going to address this mental health crisis, and at the same time, start delivering lifestyle medicine, lifestyle psychiatry at scale, and do it in a way that's actually sustainable, profitable, and creates amazing jobs on our side, and also for the improves the lives of the PCPs. So it's a lifetime in the making to figure out how to pull this feat off. But let me start with the story, right? 80% of all these antidepressants that are prescribed in the country are done by primary care doctors. And most people are shocked to hear that number, right? Only 10-20% are done by psychiatrists and specialty mental health care. And it's because of the supply demand mismatch. So the answer is actually to bring psychiatry and mental health services to primary care. In the end, the separation between the body and the mind was arbitrary and ill-founded. There's no, you need to handle both, and we were talking about that, right? Like the diabetic needs to learn behavior change, needs to not be depressed. The depressed diabetic wakes up in the morning and will take a pint of ice cream and end up in the emergency room with diabetic ketoacidosis momentarily. And so everyone knows that when you treat the mental health burden in a population, you tremendously drive down the cost of care and improve the lives of your patients. So there's this model of care called collaborative care. It's about 30 years of experience we have now as a profession in it. It was pioneered in the University of Washington. There's over 90 randomized controlled trials at this point that show that when you take a psychiatrist, a therapist, and you have some sort of registry where you're measuring mental health outcomes for a population longitudinally, you get results that are comparable, if not better, to specialty mental health care. It's an amazing finding. And when you build these models of care out, every $1 spent leads to $6.50 of downstream savings for the healthcare system. Um, so it's great. Why isn't everyone doing it? Right. And, if you think about it, mental health should be a primary care function for a great many people. Like diabetes, less common than mental health conditions. Right. But if every diabetic thought they needed an endocrinologist, the result would be millions, maybe millions of dead diabetics on the street. In the end, it has to be done by the primary care doctors. It's a population kind of illness. And so somehow mental health fell in the crack and wasn't getting treated like this. And so collaborative care is a model of care that brings it back home. You give excellent support to a PCP, and you teach them how to do appropriate mental health care, and you support them every step of the way. When I was at Kaiser Permanente, I built one of these models during my tenure there, where I covered 200 PCPs taking care of 500,000 patients with a small team of mental health clinicians. And it can be done. It can be done in many different ways, and it's amazing. So my thought is to answer President Biden's call. In 2022, in his State of the Union address, he announced that collaborative care was one of his signature initiatives for solving the mental health crisis, that we have to deliver effective and appropriate mental health care in primary care. And so he actually did something that was amazing. He got every insurer in the country and Medicare, and I guess like nearly 40 out of 50 state Medicaids now, the rest are coming online, to pay for collaborative care, 2 CPT codes that actually pay a PCP when they work with a psychiatrist and a therapist to deliver this care. And they pay reasonably well for it. So that means there's an opportunity for everyone who has a PCP to have high quality mental health services that are paid for by their insurance company, which is epic. To me, shot on goal. Like, that's where we go. And so my idea with intuitive mental health is to build a traditional collaborative care model. Well, let me talk about the pain points, right? You can't expect a PCP to go find a psychiatrist and hire them, and a therapist and hire them. First of all, they don't exist. They're all busy in their private practices. And even if you could, it's not exactly an easy thing to manage and whatnot. And then when those programs are implemented, there's a lot of balls in the air, right? Like calling back patients, figuring out how people are doing, referring people to hospitals, outpatient treatment programs, keeping track of loops, insurance calls, supporting PCPs in psychopharmacology, checking blood levels, monitoring these therapeutic drug levels. I mean, it just goes on, educating the patients. So it's a lot of work, and it takes a lot of operational excellence. So IMH, intuitive mental health, is my answer of how we address that, to bring that turnkey experience to a PCP. They push a little red button next to them every time someone shows up with a mental health concern, and we take over. And we do a comprehensive, integrative assessment. We find out their lifestyle variables. We collect hundreds of data points on their entire mental health history. They meet with our teams, and we assign health coaches and a psychotherapist to them. We follow them longitudinally. And for the patients who are appropriate for the PCP to hang on to and do work with our support, we support that process thoroughly, giving recommendations to the PCP, giving them instant access to a psychiatrist when they have any questions. And for the patients who are not, we handle the arduous work of finding an appropriate treater for them. and managing the referral and making sure they get placed and closing the loop and keeping our PCPs educated. And meanwhile, we keep in touch with our patients and check in with them longitudinally and continuously and find out their needs and continue them on a journey of increasing their lifestyle. Right? Like, how do you start sleeping, exercising, eating, mindfulness, and targeting them? And we do it very efficiently. So then IMH is bringing this kind of beautiful mental health care delivery system to the PCP and then executing it with operational excellence using state-of-the-art workflow optimization, workflow management tools. It's my first degree coming into focus, and take them on a longitudinal journey through their acute care episode and beyond. And we're able to do this leveraging technology to the max with the advent of our generative artificial intelligence. We're able to turn our clinicians into give them superpowers, and able to lever up what we thought was possible. And I think that this AI revolution is just beginning. We're in our first inning. I'm just excited to see what happens in the next 6 months, not to speak of in the next 3 years. And so I believe that there's a way that I'm going to fulfill my vow that I made 20 years ago, which is to deliver high quality mental health care to everyone. And IMH is my tireless attempt to do so. We'll see. It's in the early days, and we're starting to see our first patients now, and we're blown away by what we're able to pull off, particularly with these um, generative AI models.
I believe it, Ravi. I mean, you've certainly been backstage for several promising ventures in the past, and some of those you've highlighted here. Something that we've talked about offline, online, and with other people. I think at least when I have conversations with my students, my trainees, we talk about the word holistic is a very sexy word, right? So we're both osteopaths by training, and in the osteopathic tenets, we talk about the mind, the body, the spirit, things that you've highlighted. If you don't have peace in mind, it's a bit harder. Every other manifestation from the physical aspect is going to make life a little bit more challenging. So you do need to start there treating. That being said, though, when we take a look at that supply demand issue that you also highlighted at the outset of this conversation, we have to try to figure out how to solve this problem. Some of the things that you highlighted with AI. And one of the pieces of conversation that I hear all the time is that, AI is never going to be able to replace that human connection, right? The empathy. It's never going to be able to exhibit that. When, in fact, we've had prior guests who've come out and actually talked about, I think, Darshana, you've actually told me this as well, is that, what we're seeing is that AI actually does a better job at that. And so I'm curious to get your take, because you've got the engineered mindset. You're a true psychiatrist at the forefront, making that connection. You've got that philosophy background. Is that something that excites you? Is that something that worries you? And, if you are worried, like, I'm curious what those worries are.
Wow, that's quite a good question, Altosh. And obviously, I think about this stuff quite a bit, right? Um, Let me just say that in a collaborative care model, we're able to lever a psychiatrist with just a conventional, no technology, track things on an Excel spreadsheet, like how patients are doing. You can go take a psychiatrist from 500 patients that are private practice to nearly 5,000 patients that mind is able to weigh in on. With AI leverages, that number can go 10,000, maybe even higher. And so, scale is something that these models are going to be able to do us. But I think the point is that they're not designed, in my conception, to replace the humans. It's to make us even more human. It's to surface to the psychiatrist, for example, everything that they want to know about this patient. Just conversation. Any hospitalizations? Ever any history of psychosis? How many times do they do XYZ? And the information will just flow instant, real time, because these models are keeping track of everything in the healthcare system. So um, that's one way to use AI. The second aspect is the connection aspect. And years and years of psychotherapy research. This is something that's blew my mind as a resident. Is it psychoanalysis? Is it cognitive behavioral therapy? Is it psychodynamic psychotherapy? All these different modalities. At conferences, you'd hear everyone arguing that they're better than everyone else. No one's been able to prove that any of these modalities are better than anyone else's. Fascinating. And the only thing that's consistent, it's the treatment bond alliance between the patient and the treater. So that connection seems to have the magic touch, and the connection. Peer-to-peer counseling has a nice evidence base. um, the health coaches, they have their own evidence base that's growing, and these are ready supply of labor that want to do this problem, that want to help out here. So what I'm submitting is, in this new era moving forward, there is a need for connection, but it doesn't have to be delivered by the psychotherapist or the psychiatrist primarily. It can be a team, and it can have a team of people who are more equipped, readily available, and are in higher supply delivering this. And that's a very important point. The second point of generative AI and its ability to be empathic. JAMA, Journal of American Medical Association, last year did an early study where they took a doctor's email inbox and they gave it to ChatGPT, and they also let the doctor respond. 80% of the patients preferred the ChatGPT responses, saying that they felt that the doctor understood them, was giving a more timely response and more thoughtful response. Right. So there's the old study of the Turing test, which is the classic study on deciding if there's a consciousness in a machine, and if you can't tell the difference, then A.M. Turing back in the day said that that means that there's consciousness or sentience. We've conveniently scrapped the Turing test as we've moved into generative AI, and we're finding different ways of evaluating whether the thing is sentient or not. At GPT-4, you're approaching artificial general intelligence. And at GPT-5, I was listening to Sam Altman talk about this, and we better be prepared. In 6 months, these things are going to be very human-like, and there's going to be huge issues of trust, and whether or not we are we dealing with an artificial life form, or what are we dealing with? And this is not science fiction anymore. This is like 6 months from now, we're going to be having these discussions, and it's going to be curious. Um, and definitely, people are starting to have AI girlfriends and boyfriends and finding connection with them. And dating apps are having AI partners that you can swipe to the right or left for. And so, yeah, I think there's something there. Now, whether this is good or bad, it depends in whose hand and for what purpose. So, if I were to create an AI that was designed to raise the consciousness of my population and be the ultimate mindfulness teacher and guide them on a journey longitudinally, excellent, right? We need that.
Mm-hmm.
And if Facebook develops a bot and sticks it into WhatsApp for us to chat with, and advertisements are subtly streamed to manipulate our behavior and to not even let us see what's happening as we start shifting our views and our behavior. I'm just picking on Facebook, but I don't know. Interesting company. So, so we're heading into the Wild West with no regulation, and it's truly terrifying what the possibilities are here. And even if there was regulation, the open source language models are catching up. I can run a model that's comparable to GPT-3, which is the Chat GPT that blew all of our minds from last year, on my MacBook Pro now. And that model has absolutely zero guardrails or censorship and cannot be regulated by anyone. Not to speak of what's going to happen in 2 years from now. Like, Apple's entire thesis around generative AI is to move the technology to the device instead of being a cloud-based AI like Google and Microsoft. So the compute power is going to come to everyone's phones, even smartwatches. And so these models are going to be uncensored and unregulated. So the horrors that are potentially in store for humanity are I mean, what to say, right? And so I'm focusing hard and dedicating myself to the useful uses, the uses that are going to raise human consciousness and potential and heal people. And there needs to be more people joining me on that mission. I strongly believe it, and the potential for great benefit is definitely there. I think maybe the good AIs will help us survive the bad AIs at some level, and it's going to be a very interesting journey that we're taking as a species. And no one's thought about the consequences before it was kicked out the door.
This might be a bit naive of a question, but why do we not think that it will be regulated? I mean, from everything that you've described, I've heard lots of people talk about and echo the same sentiment. I wasn't aware that Apple is planning on rolling this out into everybody's personal device. That is
I don't think they
truly
formally
terrifying.
announced it, but if I was Tim Cook, that's how I'd play my hand. But anyways, because then the privacy is there, and then the conversations are stored on your device. They can be
Yeah.
privacy first, and then they're not a big cloud player, and they're making neural cores on all of their MacBook Pro chips for processing large language models. So no one's announced or talked about it. It has to be that way.
But why do we not think that at some point there will be some type of regulation? I mean, it might take some time to catch up, but is
Oh, you
it
can
that,
regulate,
yeah,
but can you enforce it?
yeah. I think certainly with the cloud-based models, but maybe not with the personal stuff, right?
Yes. But if GPT-3 is able to run on my MacBook Pro today, and GPT-3 is quite engaging, then
Yeah.
GPT-4 runs on my MacBook Pro next year, and that's plenty powerful enough.
Yeah. Yeah. I think it is better to take the approach of just choose to look at the positive and get more people to join in and generate more of the good AI, because yeah, otherwise it's difficult to sleep at night. I can imagine.
This is great potential for humanity. My God, my mind staggers at thinking about the upside potential of generative AI in a human civilization. But it's always the negative use cases that seem to lead and exploit humanity. And so, like, this is IMH is an interesting play where we're playing with this technology and we'll bring it out responsibly and carefully to uplift humans, and potentially be able to mass deliver it in due course. But there has to be more people attempting to do this, and there will be inherently, and it'll become a trust relationship. Whose AIs do we trust? And that's going to be a key part of this dialogue by the end of the year.
Yeah. As I said earlier, humans can be difficult, right? And so sometimes we're our own worst enemies in that. But let's try to stay on the positive side, I suppose. Where do wearables fit into this? Right? We talked about the power of digital health and generative AI, and Aura Ring, Whoop. They're very promising with respect to physical health in our world. But do you see a role for them with respect to mental health and that psychological aspect? And particularly because recent news, right? First Neuralink chip has been placed into human being. And so with those brain machine interfaces, we can get some further information on what's actually going on in somebody's cranium. How do you see that playing a role, if at all?
That's it's going to play a huge role. And so, the whole theme of this conversation in some part is that the division between mind and body is arbitrary, right?
Hmm.
And lifestyle variables like sleep, exercise, um, uh, tracking diet, mindfulness, um, and particularly the biomarker of heart rate variability are heavily correlated with mental health outcomes. So, the problem is what to do with the data. And that's been like a classic point, right? Like the first generations of Fitbit would just carpet bomb you with like, okay, you did 50 million steps in this last week. Congratulations. Okay. And eventually people would just take the thing off because it's like, what do you want me to do with that, right? And so I think in this AI era, we're dealing with a different level of utility on this data. If you look at the latest edition of Whoop, the Whoop 4.0 series, they've got a AI coach built in that's watching this, and it can give you personalized insights and tips and have a conversation with you about your data. And so I think that's where this is going. I think AI is going to make wearable data orders of magnitude more valuable in optimizing our lifestyle and our health. And the form factor is getting to be very exciting, right? Like Aura Ring is really did some pioneering work with being able to get us a tracker that doesn't require our wrist and doesn't require daily charging and radiation exposure.
Ravi, what about specific markers? We touched on precision medicine a little bit, and a lot of what Whoop and these wearable companies do is that they'll also measure subjective data, as well as the objective data, such as HRV. But I want to focus on the objective data that pertains to mental health, such as neurotransmitter levels, brain waves, etc. And so my question is, how much do we have to place an emphasis on the subjective data when it comes to mental health? The data that patients are telling their providers exactly what they're feeling versus the hard objective data that we may or may not have.
Yeah, well, I like to think of this from a framework of effect size, right? Like if when we think about how we feel right now, there's like hundreds of variables that go into play, right? And then those are just the 100 we know about, and then there's probably another 1,000 subtle things going on that we don't know about, right? And so everything, if you're diabetic, you're going to have a higher risk of depression. If your thyroid is off, you're going to either be anxious or you're going to be depressed. If your cortisol is high, you have higher levels of stress, and so on and so forth. There's all these markers. Then there's our genetic predisposition that we can get from genetic studies. And, certain people have deformations of the serotonin transporter gene, and as a result, they're likely to have aberrant reactions or responses to SSRI medications or more prone to depression. And then there's the physiological data, like heart rate variability, that gives us an index of the total wellness of an organism, right? And so, yeah, all very interesting. And you'll have companies that'll come in with one thing, like cortisol, and then they'll make a huge story that this is the key. I have found the reason why people are stressed out and anxious. And these three supplements, if you take them every day, they will lower your your cortisol, and you will feel better. Maybe. And even so, was that the mechanism of ashwagandha, the ancient herb? From an Ayurvedic framework, it probably does a hell of a lot more than lower our cortisol. And it's a very special rasayana, they call it, like a nurturing agent, right? That's made out of a plant that's the relative of the asparagus. It's harmless, but it does these beautiful things to our body. So these reductionistic models are missing the bigger picture. Even our SSRIs, like they don't know that serotonin deficiency is the cause of depression. Uh, it's kind of like, okay, if I get a headache and I take Tylenol, a headache goes away. Was the problem Tylenol deficiency? Like, look, I love it. It's an empirical data set, but you have to be a man enough to like admit the deficiencies in the thought process. And look, I speak like this, but I actually went and learned from the best before I could talk like this, right? So like, it's because it might be that I just don't understand, but no, I understand. I talked to the guy, and like this is my sense, my conclusion on the matter. And so, um, so anyways, this is my take on it. And so then like I've gone kind of all the way to the other side, and like, okay, dude, if you're not sleeping, if you're getting 3 hours of sleep, that's probably the biggest cause of why you're depressed. Can we just work on that before we get into all of this precision stuff? Like, I just need you to sleep. Can we try it for 2 days? I'll see you on Monday. Let's just talk about it then. Let's try. Oh, why can't you do it? Okay, let's do it provisionally for a week. Oh, you got it. You feel better, right? And then,
Shocking.
yeah, shocking. And so now we have the answer. Anything else?
Hmm.
Right? And then the discussion shifts to, now what are we going to do to give you the strength to remodel your life? But then we avoided this entire thing about over medicalizing it and like starting them on God knows how many supplements that cost $1,000 a month and might be causing liver failure because of the carpet bombing of all these things. And it just goes. It just keeps going, man. And so sometimes you just have to be obvious and help people out. And then after you've taken care of all of the obvious things, then we can start digging if we need to, right? Like that's fair game. And the functional medicine doctors are masterful at the digging portion, but obvious things first.
Um, I love that so much because I recently had a similar experience, and I'll share that story with you guys in a second. But I think this over medicalization problem is such a difficult situation, particularly for us who are in academic medicine. And both Darsh and I, Darsh is on the other side; he's a trainee. I am somebody who works with trainees as early as medical students. And again, I'm a physical medicine provider, I'm sports medicine, and I do MSK. And I'll share the story with you. I recently had a second year medical student come see me in clinic, and he's in his dedicated board prep time. And so he's studying 12, 14 hours a day, and he's coming with some this upper trap neck pain type stuff. And so some of my trainees went to go see him and came back and like, okay, well, what do you think is going on? Like, oh, I think it's postural. I think if we do cervical corrective exercises, and he's gotten all these sexy home exercise program of YTWLs and this and that kind of stuff, had a cervical spine x-ray done. And in that, they talked about the reversal of the lordosis, which I don't know, Ravi, how many x-rays you've looked at and stuff, but that's really just bullshit radiology talk for, they call it muscle spasm is the reason for it, but it really is nothing. It's just gravity pulling down and reversing that lordosis of the spine, right? And so we're in the room having the conversation about what do we do, and ultimately I came down to after we rule out all the insidious pathologies, and luckily this person is a medical student, so I could have a conversation with them about this and say, hey, listen, you're studying 14 hours a day, 15 hours a day. You're stressed. You're not sleeping well. This is going to suck. This time is going to just suck. Like there's not much we might be able to do to make this better. And we just got to get through it. And if we have to throw a patch on your back so you a little bit of discomfort goes away so you can get back to the important part so you can pass your boards, then that's what we got to do. I can give you all the correctives. And he, a great question asked, he was like, well, do you think I should be doing better exercises? And I asked, I was okay, how many hours a day do you study? 12, 14? If it is a postural issue, do you think 10 minutes of exercise a day are going to overcorrect 14 hours of bad posture, quote unquote? No, no. I was like, dude, this is just going to suck, right? Like, we just got to get through it. And it was not the right academic answer for any of my trainees. Because I could see some of them looking at me like, whoa, like, that's not what we learned. That's not MSK and biomechanics and, good clinical medicine. And I was like, no, that's just reality, right? It's pragmatic. And I think it's so important for us to know both sides of the spectrum. So you talked about training at some of the most prestigious institutes in the world, and you've been learning from those folks who are writing these guidelines, and then you go to the other side with the Eastern versus Western. And this also brings me to the other point that Darsh and I always talk about. People like, what do you think about the Eastern medicine versus medicine? And we just say, dude, it's just medicine. There's just, like it's all under one big umbrella, and you just take the tools,
Yeah.
agnostic, as you said earlier, you take the tools from every single place and you try to apply it to the person in front of you, what makes the most sense at that time. And so I think that's really important for everybody to remember, is that like that kind of context, and you take from everywhere and see what works the best at that time. And sometimes it's just gonna be difficult, and that's the situation that you have. Um, so, with that, I think we covered a lot of amazing stuff. I want to thank you for bringing this energy and just sharing your insight from all walks of life and the experience that you had. I think that's brought a lot of value to us and made me think and question some of the things, some beliefs that I've helped maybe, or some frameworks that I kind of want to jumble up again, so to speak. Maybe I'll use your engineering assistance with that. Um, one of the things that we're being more mindful of, so to speak, is to see if our guest has any questions for us. Is there anything that you're curious about, that what we're thinking about? Certainly, there's not much that we can teach you because you've thought about things deeply. But is there anything that you have for us? If not, then we've got some things before we close.
Um, Interesting. Who would I want to ask two guys that talk to a lot of people at this line? Um, what have you guys seen in terms of the integration of physical and mental health? And what do you what insights have you gleaned from your conversations that you think could be helpful to me as I embark on this pretty ambitious project to innovate mental health care? You never know where the insights are coming from, and you guys are definitely very thoughtful.
Darsh, I'll let you go first on this one.
Yes, I will gladly go first. So, personal goals for me, I plan on obtaining a functional medicine certification with plans to practice lifestyle and precision medicine so I can really dig deep into root cause and specific tests. But, with that type of medicine comes this need for understanding mental health. There's a need for coaching, behavioral modification. It's because I can get all these tests in the world, but if I can't convince the patient to change their behavior, it's really just a waste of money for both of us, right? Because I agree with you. How do we get those lifestyle pillars in first before we get to the shiny objects? And so for me that means getting a coaching certification, whether that's through executive coaching, understanding mental models and frameworks. I really do have this deep passion for philosophy as well and understanding the human condition. So if you look behind me, I have the works of Jean-Paul Sartre, Viktor Frankl, Stoic books from Marcus Aurelius and Seneca. And when you read their works, you really start to develop this insight for how people think about their lives and how humans are brought up in this world. And it might be a long-winded way of me saying that I think the understanding of the human condition from providers is what's truly missing. Like you both said, there's a lot of over medicalization, and I think it stems from providers solely relying on their training and not going out to grab insight from other sources. And thus, you have a human talking about the human condition to another human who doesn't understand their own human condition, right? And so, in order for that to be a success, I think it needs to be a conversation that's broken down layer by layer. And the patient needs to trust you, understand you, have this vulnerability in knowing that you've studied the human condition and that you're willing to approach it step by step with them. And so, I think for me, that's the biggest way I can incorporate mental health into my own practice. One of the gaps I see is that a lot of providers aren't sure what their role is when it comes to mental health. And so they're quick to consult out, right? And that's where a bulk of this conversation came through. And obviously with IMH, this is the problem you're out solving. But those are just some of the insights I have. I love what you're doing with IMH, and I really think there's this need for functional lifestyle perspective at the same time, decreasing the burden. So people have these specialized providers, a specialized team to take care of something that I believe can almost always cure other comorbidities and chronic conditions that patients suffer from.
Darsh, you're spot on, and like I'm heartened to see you going in this direction. The key is not to also minimize the medical sciences and all the tremendous achievements and the technology that's there. So I'm like literally ambidextrous as an allopath and as an integrative doc, and there's no bias in me towards each one. So what's really important is us to break our identity as an allopathic physician and to take on the role of healer. Like our job is to help these people get better, right? And to broaden our lens at understanding what the situation is and knowing which card is to be played at which point. And yeah, and I think that's great and um, love it.
And real quick here, I'll just add, Altosh, I actually sent you this podcast, but Ravi, I'm sure you've heard of Brian Johnson, who's created Venmo,
Yes.
yes, on a mission to never die. So yeah, he had this very interesting conversation on a podcast with Rich Roll that I would highly recommend listening to. It's actually about his perspective on the human condition, but he's on the other side of the spectrum with over medicalization, right? So he's getting every single test done to understand his body, spending $2 million a year to be exact, and he's doing this to understand in a way why humans are addicted, why humans are okay with suffering and living an Epicurean lifestyle. And so now he's almost living this life of enlightenment, and he says he feels like the Buddha. But I think you guys would really, really enjoy this conversation, especially
Yeah.
after everything we're talking about here.
Yeah. Send me a link.
Yes, definitely will.
Yeah, I can't wait to get into that. Yeah, I think, this point that you brought up earlier about allopath versus osteopath and conventional versus functional integrative, that's such a disheartening thing to me. And I'll see this, right? We've even had people who've come with different, I mean, again, we mentioned that we've been doing this for greater than 3 years, and, people come from all backgrounds. We've had some really heavy scientific discussions in rooted in quote unquote evidence. And then we've had some people talk about things that some people would quote unquote say, oh, that person's a quack, which is a term that I really dislike. And I love that, again, we're kind of saying the same things. And so maybe if there is a trainee listening, I would just encourage them to pick up as many of those cards as you possibly can. Right. And that's where we acquire these skills, something that you did, right, from an engineering background, and from whether it's a manual therapy thing, and whether it's, this establishing rapport with your patient, and then know when to play which card. And I think that is going to be the mark of a brilliant physician, and just a brilliant diagnostician, somebody who is going to be able to solve the issues of the human condition as we're speaking about. And the other piece I'll say to your question earlier, Ravi, we most of the patients that are walk through my clinic is because they're dealing with pain, right? And I know you've had experience in this as well. And the I think when it comes to pain, one thing I've realized in my earlier career, that a lot of that, in that sense, the human condition is lack of human connection. And I'll tell you, I think even the most successful physical therapist that I work with, the one I think gets the best outcome for some of structural issues, are the ones that establish are the best at establishing therapeutic alliance, which is a term that I've stole from my friend Dan Pope. And it's just building good rapport, right? Understanding that if somebody comes in with a labral tear in their hip, there's so much more behind that, how that's affecting their quality of life, and how it's causing disability, and what that's doing to their emotion, and what they feel like. And so a lot of times, some of the best physical therapists in there, I know, it's not even about because they have the sexy certifications, or they're the smartest in terms of programming exercises, what that is, but it's just the connection and what they can do to troubleshoot what's going on up here. And that's not something we spend enough time in the physical medicine, quote unquote, realms, because we have created this somewhat dichotomy just to make it simple for people to follow along. But we know that there really isn't, right? It's all one thing, as you said earlier. So I'll leave the listeners with that to think about, because I do think this has gotten to be a very meta conversation, which is something that we enjoy very much so, but maybe others not so much. So Ravi, with that, I'd love for you to tell our audience here, is like, what is next for you? I mean, you talked about some amazing things that you have plans in the short term and the long term future for IMH to work on. But what's something that you're super excited about in the next 6 months out of the things that you're planning for? And then where can our audience follow along with that journey, and follow you and more about what you're doing at your company?
Well, IMH is consuming a good deal of my attention these days. It's building these companies is no jokes, but um, amazing. Somehow I have the energy of a 20-year-old again, so I'm loving every day of it. We're starting to see patients with our first customer, the Texas Center for Lifestyle Medicine. And we found a wonderful partner, PCP, that is really category defining and trailblazing in this integrative model of medical care. And so we're going to be collecting and publishing and sharing our experiences as we go along. If people want to follow along, reach out to me on LinkedIn. I'm there, and I always love hearing from people who are interested in joining this journey and being in parallel journeys too. We need enough of us working at this line to get this job done. You can also check out our website at intuitivementalhealth.com and learn a little bit more about the company.
Well, Ravi, Dr. Hariprasad, I just want to thank you so much for coming on here. You're obviously very brilliant, and I love everything that you're doing to solve this mental health crisis. A lot of it makes sense, and I just really enjoy listening and hearing about how you think, and it all just comes from a different perspective. And I know you're out there trying to gain insight from different sources. You mentioned the Roomba earlier, and I really felt that this conversation had that Roomba bouncing off different facets of mental health. So these are really the types of conversations that we enjoy having here on the podcast. But with that, our final question is, how do we add the health back to healthcare?
Well, I think we talked a lot about that, right? But thinking out of the box and meeting people where they're at, and not feeling like we need to be limited by what we um, not being too reductionistic in making assessments and looking at people. And I also think that the technology that we have at our disposal, the generative AI, is going to make us more human as physicians. We're going to spend less time documenting. We're going to spend more time connecting with our patients and see a lot of work getting squeezed out of our day so we can get our lives back. And that's exciting. Yeah.
Awesome. Thank you so much.
Pleasure.
Thank you, Ravi.
Thanks so much for tuning into another episode. If this conversation vibed with you, please go ahead and leave a rating and review and share it with your loved ones and your friends. Spreading the word helps get this episode into the hands of others who may benefit from it. I want to thank our team, Haritha Yepuri for social media, Ethan Ju for video, Zainab Lugmani for research, and Sarah Khan for our upcoming newsletter. And as our disclaimer always goes, everything in this podcast is for educational purposes only. It does not constitute the practice of medicine, and we are not providing medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues. We'll see you next week.